I want to welcome everybody to tonight's educational program, the San Antonio Breast Cancer Symposium update with Dr. Jessica Tao. Dr. Tao is a medical oncologist specializing in the care of patients with breast cancer. She co-leads the Cancer Center-wide Johns Hopkins Molecular Tumor Board, a multidisciplinary effort to interpret complex genomic information and provide individualized precision oncology treatment recommendations to patients with all types of cancer. In addition to caring for patients, she maintains an active clinical translational research program dedicated to developing novel treatments to patients with advanced cancer. Her expertise and research focus on finding and targeting the molecular changes that drive a person's tumor and understanding novel mechanisms for response and resistance to targeted therapies. A second major area of her research is development and application of liquid biopsy technologies, including circulating tumor DNA and the early detection and disease monitoring of breast cancer. And Dr. Tao, we're so happy to have you here with us. And if I missed anything or you want to add anything, please feel free. And I'm just going to turn it over to you.
Thank you so much, Stephanie, for the very kind introduction. And I'm just so delighted to be here and really appreciate the invitation. I'm glad to be discussing and providing an overview of some key highlights from our breast conference last month, the San Antonio Breast Cancer Symposium. And we have a cozy group today, so this is meant to be interactive. I have slides and some key highlights prepared, but please don't hesitate to interrupt and ask questions if that at any point during the presentation. So let me see if I can share my screen. Actually. I'm actually having trouble seeing if I can how to share my second screen. I'm not sure. Am I displaying a PowerPoint presentation?
There you go.
Okay. Is it showing the presenter view or the actual slides? Sorry, I can't. Is it?
It's showing both.
It's showing both. Okay.
Well, it just has the notes on the side or in the next slide. So
okay.
I don't know if you can make it bigger, maybe that would help.
Yeah, I think this is presenter view. So let me see if I can try again.
Okay.
Sorry about this technology, right? You'd think I'd know.
I know when it works well, it's so good, and when it doesn't. But also too, if it's whatever you want to show it, we're flexible, so it doesn't have to be.
Maybe I'll I want to show just the slides on the right in presenter view. Screen sharing. Okay.
Yes, perfect.
Is it go?
Yeah, you just had it.
Yeah. Okay.
I still have it. You know, it's sending out 4A.
Is this? Oh, is this better now? Is it showing? I just swapped. It's showing just the slides and not like notes on the right.
Right. Yes. Okay. Right now it looks great.
Okay. Perfect. Excellent. So Yes, as Stephanie was saying, I am a breast medical oncologist at Johns Hopkins, and am also a clinical translational researcher. And part of my research interest involves precision oncology. And as part of that, I co-lead the Molecular Tumor Board, which helps review individual tumor profiles to provide a treatment recommendation for patients. These are my disclosures. So San Antonio Breast Cancer Symposium, I'm sure this audience is familiar with this, but for those that don't know, it is our annual meeting. It occurs every December in Texas, in San Antonio, and brings together over 10,000 breast cancer researchers, clinicians, patients, patient advocates, all interested in learning more about breast cancer and advancing the field so that we can hopefully develop new ways to detect and treat breast cancer. This year, I would say, was truly a banner year for breast cancer and our SABCS conference. There were so many studies that were presented, many studies ranging from diagnostics to early detection to metastatic treatment. I feel like it was a bit difficult to select a few studies, but hopefully I'm going to be covering some of the key highlights and what I felt were particularly impactful studies. And I tried to choose a couple of studies within each domain, which I've shown here. So this is an outline. It's a bit of a acronym soup here, but I'm going to get into each of them. The first, there's an emphasis on metastatic breast cancer. So I'll first be talking about ER positive, HER2 negative metastatic breast cancer. And there are two studies that I think were worth mentioning, the INAVO 120 study and EMBER-3. And then there was a key, very impactful study called the PATINA study that is an ER positive, HER2 positive breast cancer, which is what we call the so-called triple positive breast cancer. In ER positive early stage breast cancer, there was a retrospective or post hoc analysis of Taylor RX that looked at the benefits of anthracycline-based treatment, which is a type of chemotherapy that's colloquially known as the red devil. So this I felt was particularly relevant and impactful. And then from the surgery side, there was the ENSEMA study, which looks at omitting node sampling and the outcomes and safety of doing that. And finally, for adjuvant monitoring, this falls under the early stage category as well, and using novel technologies such as ctDNA, which is a blood test, to help follow individuals with early stage breast cancer and evaluate the clinical utility of treating positive ctDNA or positive tumor DNA in the blood following an early stage breast cancer diagnosis. INAVO 120, the first study, was not specifically presented at San Antonio this year, but I felt it was worth mentioning because this was a new FDA approval that happened late last year, around November of 2024. The PI3 kinase pathway, this is an introduction, is a pathway that's mutated commonly in breast cancer, in particular ER positive breast cancer. There's around 40% of ER positive breast cancers harbor a mutation in the PI3 kinase pathway. And as you can see here, the PI3 kinase pathway, which I've shown on the left here, there's really multiple nodes that can be targeted. And this represents the evolution of the therapies that have been developed that target this pathway. The most recent being inavolisib and palbociclib and fulvestrant in 2024. Each of these target a particular biomarker, which I've shown on the right here. So green means a biomarker for which predicts response to a drug. red refers to a biomarker or a gene mutation that predicts resistance. And so you can see really over time, we started out with mTOR with the approval of everolimus in 2012, and then alpelisib, also known as Piqray, was approved in 2019 for PIK3CA mutated ER-positive metastatic breast cancer. And then in 2023, capivasertib was the first AKT inhibitor for patients whose tumor have either a PIK3CA mutation, a PTEN mutation, or an AKT mutation, so mutations along this entire pathway. And then, of course, inavolisib. Inavolisib came out of the INAVO 120 study. This was a relatively medium-sized clinical trial involving around 300 women, and this was for a particular patient population. So this was in what is considered, would be considered an endocrine therapy resistant breast cancer. Definitely an area of unmet need. These are individuals whose cancers progressed during or within 12 months of adjuvant endocrine therapy. And patients were randomized to receive the triple combination of inavolisib plus palbociclib plus fulvestrant versus standard of care therapy, which was fulvestrant and palbociclib. And one of the things that I think is worth mentioning for this trial is that it was very patient-centric. So, when we're thinking about clinical trials, many of them, for example, require a biopsy. This study did not. And the majority of patients were actually enrolled based on ctDNA, which is a blood test that looks at DNA that's shed from tumor cells into the bloodstream. And the PIK3CA mutations were detected in that blood test. Now, we can kind of like hem and haw about the accuracy of blood or the concordance between blood PIK3CA mutations versus tissue ctDNA mutations. But for all intents and purposes, ctDNA is very sensitive. It's also very specific for the presence of these PIK3CA mutations. And it's really quite incredible that 93% of the patients were enrolled by ctDNA. The study found that the triple combination extended the progression-free survival by almost 8 months. And you can see that in the standard of care arm, which is fulvestrant and palbociclib, the progression-free survival was only 7.3 months. I mean, this is a patient population that we need to do better in. So this is first-line therapy, remember. So these patients have had early-stage breast cancer, and then their cancers recurred within a year after stopping their adjuvant hormonal therapy or their endocrine therapy. They also had these PI3 kinase mutations. And so the first-line therapy, only 7.3 months with standard of care. With the addition of inavolisib, that was 15 months. That being said, these studies report out progression-free survival as an initial outcome measure. Overall survival data is immature, and so it remains to be seen whether overall survival will improve with this combination. But based on this data, with the triple combination, the FDA approved this combination for patients with high-risk ER-positive PIK3CA mutant metastatic breast cancer. Okay, so I'm going to move on to the next study in ER-positive metastatic breast cancer. This is the EMBER-3 trial. So this is relevant, I think, because the field of ER-positive breast cancer is moving towards the development of what we call next-generation endocrine therapies. So many in this audience might have heard of fulvestrant. Fulvestrant is a SERD. It's a selective estrogen receptor degrader. It works by degrading the ER receptor which is present on the majority of breast cancers. Some 80 to 80% of breast cancers have the ER receptor. And fulvestrant is an injection. It's a shot, literally a shot. And there are concerns that the bioavailability, meaning that the ability of this shot to be absorbed well, is variable. And so for a long time, people have been working on developing oral versions of this class of medications. And imlunestrant is it's Eli Lilly's oral SERD. It's one such oral selective estrogen receptor degrader. There are others that are in development or even FDA approved. So elacestrant or Orserdu is one such, is currently the one FDA approved oral SERD available right now for ESR1 mutant metastatic breast cancer.
Dr. Tao, can I just interrupt you for one sec? We have somebody put in the chat, which I just think was helpful.
Okay.
She said many of us, like me, might not be familiar with some of the terms you're using. So do you mind providing some basic background for those of us who are not familiar with terms like ctDNA, chemo outside of your own treatment, et cetera? And I just think that was just helpful, because I think sometimes too, like when we know something so well, and maybe some people do know, but I think the majority don't know so well. So I think that was a really good sort of just ask.
Oh, no, thank you so much for that. I appreciate that. And please, yes, exactly. Please don't hesitate to interrupt if I'm, not explaining. Not explaining this.
No, you are.
Well, or there are questions about. So that's perfect. Maybe I can address that question. ctDNA stands for circulating tumor DNA. Our cells all shed into the bloodstream. So healthy cells, tumor cells, they all die and release little bits of their DNA into the bloodstream. And as a whole, that's called cell-free DNA, meaning like DNA that's free from the cell and just is floating around in the bloodstream. So normal cells do that, but also tumor cells do that too. Cancer cells do that. And we've developed ways to distinguish circulating tumor DNA from the rest in the background, and to look at mutations that are in the DNA that are released from the tumor cells. So it's another way to get information about the cancer that doesn't involve a biopsy. It's literally a blood test. And there's circulating tumor DNA refers to, in general, any DNA that's released into the bloodstream from the tumor cells. And you can do tests on that, like sequencing or looking at the changes in the DNA, mutations in the DNA. This is different from what you get from mom or dad, inherited causes. These are changes in just the tumor cells. And there can be mutations that are detected in that, for which there's a drug or a target that can sort of be matched to that mutation. Hope that answers the.
Thank you so much.
Yeah. So by way of background, imlunestrant is a drug. It's an oral. It's like let's say almost like an oral fulvestrant. It works by degrading the estrogen receptor. It's CNS penetrant and active in what's called ESR1 mutant breast cancer. Breast cancer that harbors what's called an ESR1 mutation, which is a mutation in the estrogen receptor that renders it not active, regardless of whether estrogen is present. This was a phase 3 study. Patients were randomized to one of 3 arms, which included imlunestrant, which is the investigational, which is the drug being tested here, standard of care endocrine therapy, which would consist of fulvestrant or exemestane. So fulvestrant is that injection. It's literally like a very oily injection that's injected into the buttocks and not absorbed and may have variable bioavailability or absorption. Or exemestane, which is a pill type of hormonal therapy. And the third arm in the study was imlunestrant and abemaciclib. So this is the study design. So in this study, this is for patients with metastatic ER-positive breast cancer who had progression on first-line therapy. So the current standard for ER-positive metastatic breast cancer is to take an aromatase inhibitor, which is a type of pill that works by reducing the estrogen in your body so that there's less estrogen fertilizer around to fuel the cancer cell's growth. And that's typically paired with what's called a CDK4/6 inhibitor or something which is a type of oral therapy that works by blocking the cell cycle or keeping the cells from dividing. And so this was following that first line treatment. So the cancers had grown after the first line of therapy. And so patients in this trial were randomized to the imlunestrant, the fulvestrant. Both of these are drugs that work by degrading the estrogen receptor because we know that in a proportion of women whose cancers grow on an aromatase inhibitor, even if there's no estrogen around, which is what the aromatase inhibitor tries to do, the cancers will grow despite that. And so this degrades the estrogen receptor itself. And so there's no estrogen receptor around to signal and tell the cells to grow. And then the third arm, which was added later, was imlunestrant plus abemaciclib, which is one of those CDK4/6 inhibitors. You can see the randomization here. So each arm had around 300 women, and then the imlunestrant and this combination arm had 200 women because patients joined later in this arm. This arm was added later in the study.
Can I just read one thing in the chat?
Okay.
Someone wrote, I thought receptors are good. I'm triple positive. Why would you want to degrade a receptor?
That's a great question. Thank you for that. That's a great question. So receptors are good in the sense that that means that there can be targets. So by triple positive, we mean estrogen receptor positive, progesterone receptor positive, and HER2 positive. And so if you have, for example, the estrogen receptor, then that means that your cancer is dependent on estrogen to grow. Like estrogen acts like a fuel for it to grow, which is why in metastatic estrogen receptor positive breast cancer, the first go-to treatment is an aromatase inhibitor, which works by reducing the estrogen fertilizer. The problem is, and the issue is that eventually the cancer will figure out a way to grow and outsmart this aromatase inhibitor treatment. It'll figure out a way to grow even with no estrogen fertilizer around. And one of the ways that it does that is by acquiring a mutation in the estrogen receptor itself, so that even when there's no estrogen around, it'll still grow. It'll still signal and tell the cells to grow. So we try and overcome that by getting rid of the estrogen receptor. If getting rid of the estrogen fertilizer doesn't help anymore, then we can try and degrade the receptor itself. And so drugs like fulvestrant or imlunestrant work by to try and overcome resistance to those estrogen reducing medications called aromatase inhibitors. And so they are typically what's called second line treatments after progression or growth, after the aromatase inhibitors stop working. So basically, eventually, ER positive metastatic breast cancers, it doesn't matter whether you have ER anymore. The cancer is going to grow even without estrogen around. Does that answer the question? Sort of.
I think that was great. Thank you.
Yeah. And so these are characteristics. So one of the things that we look at in clinical trials is to make sure that each of the arms is equal. So we're not developing a bias for one arm. Because like, for example, like say in one arm, all the women were 80 years old versus in another, they were 40 years old. You want to see similarities among all three arms. And so you can see that across all three arms, around 30 to 40% of patients had this ESR1 mutation, which is pretty typical. Typically around 30 to 40% of ER positive breast cancers acquire or develop an ESR1 mutation, and around 40% of patients had these PI3 kinase pathway mutations that we had just talked about in the previous study. Most of the patients received, around 60% of the patients received a CDK4/6 inhibitor, which is this cell cycle inhibitor that is typically given together with an aromatase inhibitor in the first line setting. And what you can see here is that among patients with ESR1 mutations, imlunestrant was better than standard of care endocrine therapy, which is the fulvestrant or the exemestane. So the median progression-free survival means the time that you're living without the cancer getting worse. So was 5.5 months versus 3.8 months. So obviously there's a lot that needs to be done here. We're talking about just months for both drugs in the second line setting. But imlunestrant in the ESR1 mutant population, better than standard of care. But what about among all patients? The drugs were the same. And this is similar to results from elacestrant, which is another oral SERD, the one that is FDA approved now. So elacestrant is only approved in ESR1 mutant metastatic ER positive breast cancer. Then the investigators did something interesting. They decided to add abemaciclib to imlunestrant. And so this idea of switching CDK4/6 inhibitors is not new. There have been other studies that have shown that switching the type of CDK4/6 inhibitor. So remember, in the first line, most people are getting, at least in the US, most people are getting not just an aromatase inhibitor, but they're also getting a drug like ribociclib or palbociclib. In this case, the majority of the participants had palbociclib or ribociclib in the first line setting if they had a CDK4/6 inhibitor. They are getting abemaciclib added. And so you're adding a second drug onto the imlunestrant, and that increased the median progression-free survival to 9.4 months from 5.5 months with one drug by itself. I would have argued that the better comparator for this would have been fulvestrant plus abemaciclib, rather than, because you're really comparing two drugs against one. Like adding a second drug. It would have, I think, been a more fair comparison to do fulvestrant, the injectable standard of care drug, plus abemaciclib. But so I think it's not clear what to do with this data. And if this is going to be a combination that ends up getting approved by the FDA. This is divided by ESR, again, by patients whose cancers have the ESR1 mutation versus without the ESR1 mutation. With the ESR1 mutation, the progression-free survival was 11 months. Without an ESR1 mutation, 9.1 months. So again, this drug is more active among ESR1 mutant ER positive breast cancer. And then this is a further subgroup analysis based on analyzing a part of the study population, those who had prior CDK4/6 inhibitor versus those with the PI3 kinase pathway mutation. I won't focus on this. And then looking at overall survival. So this is a key endpoint. Often primary endpoints are progression-free survival because those results come more quickly, and overall survival is something that needs to be followed for a long time. The overall survival data is immature, which means all the results haven't been filtered in yet. So the trial will continue and continue to follow these patients for years and years. But there's a trend towards improved overall survival for imlunestrant compared to the standard of care, which is what we have now. I think an important part of all trials, including this one, is safety, side effects, tolerability. I would say that in general, fulvestrant is very tolerable. And, in the beginning, people were like, oh, okay, well, oral SERDs, they're very tolerable as well. These are still hormonal therapies. But as these trials have borne out, we've started to see oral SERDs can have very unique and sometimes peculiar side effects compared to current endocrine therapies like fulvestrant and aromatase inhibitor. We've seen things like ocular toxicity. I mean, these are rare things, but ocular toxicity, higher rates of nausea with Orserdu or elacestrant. I would say that the one thing with imlunestrant, and we were a participant at Hopkins for EMBER-1. So this is EMBER-3, but for EMBER-1 with imlunestrant, I would say that compared to other oral SERDs, that imlunestrant seems to have a generally well-tolerated safety profile. So it is, I think, one of the cleaner SERDs with similar rates. This is called a treatment-related adverse event, so side effect. I'm not minimizing any of these side effects. I mean, one can have nausea and it can be grade 1, which means low grade. And if you have that constantly and low grade nausea, that can be a very impactful and life-limiting and disruptive type of side effect. So I'm not minimizing this at all. But I can say that compared to the other SERDs, that imlunestrant seems to be cleaner, and that there are comparable rates of adverse events with imlunestrant compared to standard of care endocrine therapy. And then in the combination with abemaciclib, of course, we see a lot of diarrhea. I think a lot of that is attributed to the Verzenio or the abemaciclib that's seen in the combination arm. And you can see in both arms, right, some people are discontinuing this treatment because of the side effects, 4% in the imlunestrant versus 1% in standard of care. But overall, generally tolerable. So key takeaways from EMBER-3. Among all patients, meaning those with and without ESR1 mutations, imlunestrant was about the same as standard of care, what we have. However, among ESR1 mutant ER-positive metastatic breast cancer, which occurs in about 30 to 40% of patients, imlunestrant was better than standard of care. In all patients with a prior CDK4/6 inhibitor, the imlunestrant plus abemaciclib, the combination was better than single-agent imlunestrant. And then overall survival data it was immature. It's trending towards a benefit with imlunestrant, but that remains to be seen. And then side effect-wise, imlunestrant about similar to standard of care endocrine therapy. So that kind of concludes my section on highlights for ER-positive metastatic breast cancer. If there aren't any questions, I wanted to move on to HER2-positive metastatic breast cancer and highlight a study called PATINA that came out.
Dr. Tao, I'm just looking at the time, and I know we also want to get to, of course, we want to discuss metastatic breast cancers because they're so important, but I want to also have time for cancers that are not metastatic. So,
Absolutely. Yeah.
okay.
Okay. So I can, yeah. It's until 7:45.
Yes.
Okay. So Patina, really interesting study. This is actually a late breaking abstract. Sometimes there are just studies that really surprise us. And this was definitely one of them. So late breaking abstract meaning like I think days to weeks before the meeting, the results from this came out and were presented because they were so compelling. So Patina was a study that looked at triple positive breast cancer, so ER positive, HER2 positive, metastatic breast cancer following first line treatment. The standard of care, so I guess a little bit of background, about 15 to 20% of patients have a breast cancer that overexpresses HER2. And truly one of the backbones of therapy has been anti-HER2 therapy. But there is rationale for also blocking CDK4/6 in HER2 positive disease. So these are those cell cycle inhibitors that we had touched on in the previous study. So this study was looking at, I'll skip over this, men and women who had finished their first line therapy for metastatic HER2 positive breast cancer, which typically consists of a taxane, which is a chemotherapy drug, plus Herceptin and Perjeta, or trastuzumab and pertuzumab. And you finish this induction phase with the chemotherapy for 6 to 8 cycles, and then you enter what's called a maintenance phase, which consists of Herceptin and Perjeta. And because these individuals are triple positive, they have the ER expression as well. In the maintenance phase, the standard of care is also to add endocrine therapy. So this study asked, well, what if we add palbociclib, a cell cycle inhibitor, to the maintenance phase? So it's randomizing women to trastuzumab plus pertuzumab plus endocrine therapy, that's standard of care, to standard of care plus palbociclib. And this is the progression-free survival in the triple combination arm compared to anti-HER2 versus standard of care. And the difference was 44 versus 29 months. I mean, this is significant. This is over a year difference. And when this was presented, literally some people in the audience were gasping because I don't think people expected this profound of a difference with the addition of a CDK with a palbociclib. Overall survival is, again, this is just an interim analysis, and so all of the results weren't in. It's going to take more time before we can see the overall survival results. It seems to be trending in favor of the palbociclib arm, but it's not yet mature. We're still waiting on the overall survival. So this is a common theme in in breast cancer research. It takes time to get the overall survival results, but sometimes median PFS, this can be a surrogate for like predict overall survival, not a surrogate, but an earlier endpoint. Otherwise, we would be waiting years and years to get results from these studies.
Sure. And somebody just asked, do these findings just apply to hormone receptive breast cancer, or do they also apply to triple negative?
In this study, it only applies to hormone receptor positive, HER2 positive, so triple positive. Yes. Okay. So key takeaways from this: additional palbociclib to maintenance endocrine therapy and Herceptin Perjeta improved median PFS substantially, improved response rates and clinical benefit rate, and there's a positive trend towards overall survival, but that hasn't been reached yet. Okay, so moving on to early stage now. So I think there was a key study that came out in early stage breast cancer ER positive, what's called a post hoc analysis. So it's interesting. The studies that I've presented before are what's called prospective studies. That means the study is, we're looking at the beginning, what happens. So patients are getting randomized to one of 2 or 3 arms, treatment arms, and then we're following those individuals over time and then seeing what the results are. And that's considered kind of a gold standard type of approach. TAILOR-RX, they did a post hoc analysis, which doesn't mean it's not relevant. We can still learn a lot from a retrospective analysis, meaning that the study is complete, but we're analyzing a particular subset or particular question from that. And the question, so this is the study, was looking at what is the impact of anthracyclines. So there are different types of chemotherapy. Anthracyclines are a special type of chemotherapy that has a role in treatment of breast cancer, but is also associated with significant toxicity, meaning both short-term and potentially long-term side effects. It's known as the red devil. It's literally red. It can be quite a tough chemotherapy and be associated with rarely with things like leukemia, decrease in the heart function. And so as a field, we're trying to get away from using anthracyclines, or rather, I would say, try to be more selective in understanding who we actually need to use anthracyclines in. Or are there groups that where we're not going to get much benefit from anthracyclines? So that was the question that this study tried to address. It looked at the TAILOR-RX population, which was a clinical trial that looked at the role of chemotherapy in individuals with early stage ER positive, node negative breast cancer. And the arms in this study were anthracycline-based chemo versus TC, or non-anthracycline-based chemo. Many of you in here actually may have remembered or even have received TC chemotherapy. This reflects the TAILOR-RX study. It's a study that used a genomic assay called Oncotype, and basically, if you had a low Oncotype, then you just got endocrine therapy. If you had a high Oncotype, then those individuals got endocrine therapy and chemotherapy. But if you had this middling Oncotype between 11 and 25, then you were randomized to receive either endocrine therapy alone versus endocrine therapy plus chemotherapy. That was the group or study that the investigators went back and looked at to try and answer this question about anthracyclines. And so they looked at people with recurrence scores, Oncotype recurrence scores greater than or equal to 31. So this is a high-risk group. Oncotype it's a score that you get that predicts what the chance of reoccurrence is, and also what the benefit of chemotherapy. So the higher the score, the higher the chance of recurrence and the more benefit from chemotherapy. But the question was, in this study, well, for individuals with a recurrence score greater than 31, what about what chemo should you get? Would you get TC or should you get an anthracycline-based chemo? And the interesting thing that came out of this is that for recurrence scores greater than 31, among those who got chemo, there was a benefit to receiving anthracycline-based chemotherapy because sorry, this is a little bit of a messy slide. I think it was like this. So people who had anthracycline-based chemotherapy did better compared to TC, but in recurrent scores under 31, these different chemo regimens were equivalent. Similarly, for overall survival, there was distant recurrence-free survival, there was a trend towards benefit with anthracycline-based chemotherapy in recurrence scores greater than 31. So these are your tumors that are more aggressive, higher chance of coming back. And of course, what I'm trying to show here is that there's nothing special about this cutoff of 31. Oncotype is what's called a continuous variable, so it's not like a yes or a no. It's a number that's ranging typically from 0 to 50 or 0 to 100. And so what you can see here is this line, the black line, is what's called TC. That's the control. That's the non-anthracycline-based chemotherapy. And the TAC is the anthracycline, taxane and anthracycline. And you can see the higher the recurrence score, the greater the benefit to anthracycline. So of course, there are limitations to any kind of retrospective analysis. The chemotherapy was not randomized like they are in a prospective trial. So the authors concluded that anthracyclines could be considered in patients with high genomic risk, meaning high oncotype, hormone receptor positive, HER2 negative, node negative disease. And I think this does make us think, because I think historically, with node negative, we have shied away from using anthracyclines. But I think this becomes again a tailored discussion with your oncologist in cases that are particularly high genomic risk. Should we be using anthracyclines in the adjuvant setting over TC chemotherapy? Moving on a little bit, I'm actually going to just skip to the adjuvant monitoring, because I think that will be relevant for some people in this group, and skip over the surgery part, because and if we have time, then I'll go back to the surgery part. So I'm going to talk about the ZEST study. Hold on. So adjuvant monitoring. So this study tried to address a very important question. Which is, can detecting ctDNA, or these tumors DNA that's shed into the bloodstream in patients with early stage disease, and acting on a positive ctDNA result, improve outcomes? I think this is a question that plagues all of us. So meaning, say you're diagnosed with early stage breast cancer, non-metastatic breast cancer. Our goal is to try to cure this, meaning to prevent this from ever coming back and spreading to other areas in the body and becoming metastatic. However, we know that a proportion of women with early stage breast cancer will relapse, meaning that their cancer will recur and it will become metastatic, at which point, to the best of our abilities, currently, we cannot cure metastatic breast cancer. And at present, there's no way to predict individually who is going to recur. We can predict on a population level. We can use genomic markers like oncotype that I was just talking about. We can use stage, size of tumor, certain features about the tumor to try and predict who's going to recur, and then tailor our treatments around that. But we are not able to know on an individual level who is going to recur. And, I've had patients ask, why aren't we checking tumor markers? Why aren't we looking at scans and seeing if my cancer is back and metastatic? The reason for that is, to date, those tests have not proven to be effective and change outcome. And so we need new technologies and new ways to figure out and detect relapses earlier, and to figure out who is going to benefit from treating those relapses. So ZEST was one such study. Here's the study. So in order to be eligible for the study, you had to have an early stage breast cancer, so stage 1 to 3 breast cancer, triple negative breast cancer, regardless of BRCA status, or a tumor with a BRCA mutation and hormone receptor positive HER2 negative breast cancer. You completed your standard of care therapy, meaning you got your surgery, your chemotherapy if you needed it, your radiation, etc. And then you have to have no clinical sign of recurrence. And then what happens is, on this study, you enter what's called a ctDNA surveillance phase. So this is a blood test that you're getting every 2 to 3 months that on the study. and to try and pick up those tumor DNAs shed into the bloodstream. And then if you have a positive ctDNA result and no clinical evidence of recurrence, so there's the thinking that in some cases, the ctDNA can be positive in the bloodstream, but it's not it's not shown up on imaging as metastatic. And so can we intervene on that earlier before the cancer becomes on imaging metastatic, that it's just detected in your bloodstream, but it's not in the organs and metastatic on imaging. So then if the ctDNA was positive, then those individuals were randomized to receive standard of care, meaning monitoring as you would until clinical recurrence, versus niraparib, which is a drug that is an oral drug that targets what's called it's a drug that targets the DNA repair pathway, which is thought to be aberrant in triple negative breast cancer and in BRCA mutant breast cancers. So the assay, the test that was used is something called Signatera, and some of you may have heard of this or seen commercials for Signatera. It's basically what's called a tumor-informed assay. It takes your primary tumor, so the breast cancer that you originally had, it looks at 16 mutations in it, and then they develop a custom or bespoke assay against those 16 mutations, and those are followed in your blood over time. And so if they pick up one of those mutations in your blood, that means that the cancer has come back in the blood. And so this blood test was done every 2 to 3 months, and the planned sample size was 800 patients being randomized. Well, here's what happened on this study. So almost 3,000 patients were screened and consented to this study. A number of them did not enter the ctDNA surveillance phase because for example, there was insufficient tumor available to build this custom assay, or the blood specimen didn't meet testing requirements. And so this is showing what happened with the study. This is called a consort diagram. And then so around 1,900 women entered this ctDNA surveillance, of which 147 had positive ctDNA. So that means there's tumor cells in your bloodstream. And then a number of this did not enter screening or randomization because at the time that their ctDNA was detected to be positive, which remember we're screening every 2 to 3 months, which is pretty frequent, once they got a scan, the cancer was clearly back on imaging. So a number of these, it's already metastatic at the time of the ctDNA is positive. And then, so 96 entered screening, and then ultimately 40 patients only 40 patients ended up being randomized into the intervention arm, the actual part that we're trying to test, which is niraparib versus placebo. So half had a radiologic recurrence when ctDNA positive. These are some characteristics associated with ctDNA detection. So the majority of individuals were stage 3, which makes sense because the higher the stage, the more likely the chance of recurrence. And then of course, the more likely the ctDNA will be positive. This gets into prior therapies, including characteristics about the tumor, like pathologic complete response versus not. We don't have to get into the details or weeds about this. The timing of the ctDNA being detected. So the majority of the patients actually had their first ctDNA test become positive in less than 6 months after completing their standard of care therapy. So you can imagine this is a triple negative breast cancer patient population. A lot of these patients who do recur are what are called early relapses, meaning after they finish all their treatment, their surgery and so forth, the cancer comes back in under 6 months. So that was the case in here. And of course, a number of them by the time the ctDNA is detected, it's already shown up on imaging simultaneously. This is showing the recurrence-free interval of the 40 individuals who were randomized, who did manage to get into the actual intervention, the niraparib, the drug versus no drug. The number of events in the no drug versus niraparib were somewhat similar, actually. But of course, this is very, very small numbers. That being said, I still think this study was worth talking about because this is such an unmet need. And this is really the first phase 3 trial of what's called minimal residual disease guided therapy in breast cancer. So can we do something, detect breast cancer individually before it comes back on imaging? And does treating and intervening on that make a difference? However, the study was terminated early. It had to be terminated early because there were so few participants out of those who were screened who ultimately made it to the treatment arm, which is designed to address the question. So I think this is, this gets into a bigger issue, and Ian Kropp was the discussant for this presentation. And I thought gave a really beautiful and thoughtful discussion. And so these are some of his slides. This gets at the question of what's called risk stratification. We are trying to tailor the right therapy for the right patient at the right time and really try to decide what is the optimal treatment plan for patients with early stage breast cancer. Who needs more therapy because their cancers are going to have a higher chance of recurring? Who needs less therapy because the chance of recurrence is less? And how can we spare these toxic treatments? And that's only getting more challenging as there's being more treatments being developed. And at present, we use stratification markers like size or nodal involvement. So if the cancer is higher stage, then we expect it to be higher risk, which means more aggressive treatments to try and further reduce the chance of recurrence. There are molecular features that we use, such as grade, high grade, low grade, or ER or HER2 genomic features, such as this oncotype, which are helping predict recurrence and response to chemotherapy. And then functional markers like pathologic complete response, which means did your cancer cells completely go away after chemotherapy before surgery? So that's leading us to escalate therapy when needed, for example, with certain cancers like HER2 positive breast cancer or triple negative breast cancer that has residual disease after chemotherapy, and use less chemotherapy for in other cases like ER positive or HER2 positive. So we are already using these factors to help and tailor a patient's therapy after an early stage diagnosis. However, the problem with these approaches is that they're all probabilistic, meaning it's not for an individual person, it's based on probabilities. So if we're going to revolutionize how we select optimal adjuvant therapy, which means therapy after surgery, we have to go beyond these markers. And so that's where this circulating tumor DNA goes in. So this, I should have shown this earlier. This depicts what ctDNA is, right? So there's all these cells that are releasing stuff into the bloodstream. There's normal cell-free DNA, there's ctDNA with these, we are developing technologies to pick up the ctDNA. This is not super new. So there's been multiple studies now that have been borne out that have shown that the presence of positive ctDNA is strongly associated with later metastatic recurrence, meaning that if you have a ctDNA test that is positive, that almost means that the cancer will become metastatic at a certain period of time. And the lead time, the median lead time meaning the time from ctDNA positivity detection to the time that of a clinical recurrence, say that detected on imaging, is around 12 months. So we're picking up the ctDNA typically around 12 months before it shows up on imaging. And we know that in studies, we've shown that the detection of ctDNA is associated with poor outcomes. So Monarch E was a study that looked at ER positive, stage 2 and 3, early stage breast cancers. And these individuals went on to get abemaciclib and endocrine therapy. And this light blue line are individuals whose ctDNA was persistently negative, meaning they're getting their ctDNA followed. It's negative the whole time. This line, the gray line, is was detected at baseline and persistently positive, and this is invasive disease-free survival. So on this graph, you can clearly see that if your ctDNA was positive and it stays positive, then the outcomes are clearly worse than if you have persistently ctDNA negative. And so we can pick it up, but it's not perfect. And the major question in the field remains, can we use a positive ctDNA test to guide adjuvant therapy? Meaning, is there actually clinical utility to, if we do something about this positive ctDNA result, are people going to do better? Are people, and that's what ZEST was trying to get at. And I think it reflects the challenge of this type of study. So what do we need to do? So we're already there in terms of, to a degree in being able to pick up ctDNA. But we need to select relatively high-risk patients, test as early as possible from completing standard therapy, because as you can see, many of the patients in the ZEST trial, within 6 months, they relapsed very shortly after completion of their standard therapy. And then improving the sensitivity. So ctDNA testing is not perfect. You can have false positive and false negative. So even if the ctDNA is negative, that doesn't mean that the cancer is not back. If it's positive, it could be a false positive. So so this is in development. But the reason why we need to test this approach is because it's possible that outcomes like overall survival cannot be meaningfully changed in patients who are ctDNA positive. Even if we treat those patients, it does not change the survival. And we don't know that. Why do we need to establish clinical utility before going out and just doing ctDNA or Signatera on everybody? It's because ctDNA testing itself can also be associated with potential harm. So there's increased toxicity from starting therapy earlier than needed, or ineffective therapy earlier than needed. We are potentially discontinuing an effective therapy. There's anxiety regarding testing. What is my test going to come back as? A positive test. Does that mean that my cancer, I'm just sitting duck waiting for the cancer to come back? And also false reassurance. If it's negative, that could be a false negative. And so right now there are multiple ongoing studies to evaluate escalation studies in early breast cancer. So ZEST we talked about here, that was presented at this year's San Antonio, but there are multiple ongoing studies across subtypes of breast cancer that are trying to address this very question of what is the clinical utility of intervening on positive ctDNA. And I'm gonna skip ahead. So in conclusion, there are studies that show a strong association between ctDNA presence and distant recurrence, but the key is no study has shown that acting on a positive test improves outcomes, and no study has shown that de-escalating therapy, meaning getting less treatment if the ctDNA is negative, is safe. And so given the current lack of evidence of ctDNA-guided therapy in early breast cancer, what was born out of the discussion, this discussant at San Antonio, was that using ctDNA results to guide therapy should only be done as part of a trial. And it's not yet entered the field. I hope it will someday. It has not yet entered standard of care. So with that, sorry, it's 7:40, so I want to leave some time for questions. I see some questions in the chat, which I can start with.
Thank you.
Yeah. Do you recommend asking oncologists to run blood tests more frequently? That's a great question. So, so obviously there are limitations to ctDNA and how frequently one can run this test. I think for most, there are resource limitations, of course, with these tests, and you know there comes a threshold too where you wonder what is the difference between testing every 4 weeks versus every 8 weeks. I personally think every 2 to 3 months is pretty frequent for ctDNA. I don't know too many studies that have done more frequently than every 2 to 3 months surveillance. It's not clear that that would change things. For what it's worth, in the previous studies, the median lead time from a positive ctDNA result to detection of clinical recurrence was 12 months, though that may differ a little bit from subtype of cancer. So of course, in those studies, some of them were HER2 positive or hormone receptor positive, so maybe behaving a little bit different from a triple negative breast cancer population. But that's a great question. Would you discuss use of Signatera for stage 4 patients with only bone mets? That's a great question. So, okay, so Signatera is for minimal residual disease detection. So there are different types of ctDNA. The question was, would you discuss use of Signatera for stage 4 patients with only bone mets so far? Treatment of fulvestrant and Kisqali working, but with ctDNA help to determine when the cancer is going to break through and change treatment. Right. ctDNA refers to a basket term of any tumor DNA that's shed into the bloodstream. I would say that for metastatic breast cancer, stage 4, or metastatic breast cancer, ctDNA or liquid biopsies and sequencing of ctDNA has more or less become standard of care. What Signatera is different from assays that your oncologist may have used for metastatic breast cancer. Signatera is really a type of minimal residual disease detection. So it's these individuals are cancer free. They had early stage breast cancer. Signatera is trying to pick up minimal residual disease, small amounts of DNA in the bloodstream to see if they can distinguish cancer from regular normal tissue. So they have to pick up and detect that the cancer has come back and is shedding into the bloodstream. That's different from stage 4 breast cancer, of which most does shed into the bloodstream. So we're not trying to, we know that the cancer is there already. We're not trying to pick up and say, yes, there's cancer recurrence. Yes, it's versus no, there's no cancer recurrence. In stage 4 breast cancer, next generation sequencing of tissue or of blood ctDNA can be helpful in picking up, for example, acquired mutations that happen throughout the course of the treatment. So for example, like in the first section where we talked about ESR1 mutation. So that's in metastatic breast cancer. I hope that kind of answers your question. And so I would say that yes, it's standard of care to use both tissue sequencing and or blood or ctDNA sequencing in metastatic breast cancer, but not in early stage breast cancer. And the assays are different. There's a question about, was there any discussion of the microbiome? That's a great question. I'm sure there was a discussion of the microbiome, but I'd have to go back and look at specific studies. I don't know off the top of my head which studies and the conclusions from microbiome, but I do know that that's being actively studied. I knew that that's an active area of research looking. Is there, and then I see Peggy asked, is there data on staying on exemestane for more than 5 to 10 years if you've had a recurrence after taking adriamycin and Cytoxan? I don't know. I'd have to know a little bit more detail about that question, Peggy. I'm not sure if you want to elaborate a little bit about your situation or
Yeah, I had early stage diagnosis for stage 2, and then with no lymph node involvement. But I had a recurrence less than 6 months after I was done with treatment, the first year. So I did tamoxifen, but then they had exemestane, and I didn't know anyone else that was on that drug at that time. And I'm still hearing from my doctors that they don't know a lot about that. So I was just wondering, I mean, does it sound like something typical or not? That
meaning in early stage breast cancer extending the time on. So that's a very good question, and
I was just curious, I mean, because you mentioned it early on, the exemestane, and I hadn't
I
heard a
would
lot.
say that AIs can be used in the adjuvant setting. See that much of the time, not what's called a non-steroidal AI is used, like letrozole or anastrozole, but that there's some evidence that with recurrence, that switching to a class of AI, say from a letrozole to anastrozole, and anastrozole to exemestane, shows benefit. The question of how long to stay on an AI following surgery and treatment is I think, a separate question. And there have been studies that have looked at endocrine therapy. These studies have followed people out, I think, to around 20 years, but longer than that is hard. And so the short answer is that we don't know. We see benefit in extending endocrine therapy in some individuals beyond 5 years, but after 10 years, we don't know the answer to that. And so for the decision to go, beyond 10 is really an individual one. I think it's going to be a hard question to answer because it requires following people for 20, 30, 40 years. And that can sometimes be difficult in clinical research.
Well, Dr. Teo, thank you so much for being here tonight. And I know there's so much information that was shared in this conference, and to have to condense it is, definitely a skill. And we so appreciate you taking the time, sharing it with us, answering questions. This is, again, so meaningful. And I don't know if you'll be able to share your slides with me, but I know that people would like to have them if that's possible. And we do have this recording where the slides are. So, that's always something too that, will be available. And again, just want to thank you so, so much for being here with us tonight and just being so flexible and accommodating, and just really appreciate you and all your knowledge and expertise.
It's absolutely my pleasure. Thank you so much for inviting me, and it was such a treat to be able to speak with you all, and hopefully this was a little bit helpful.
Yes, no, it is. It is helpful just to have, this information and just going through it. And I think it's also too, you know, food for thought, and people can go back to their doctors and ask even more questions. So this is always helpful. So thank you, thank you. And thank you everybody for being here tonight. So nice to see all of you.
Thank you.
I hope everybody has a good night. And thanks again, Dr. Tao.
You're so
Thank you.
welcome. Have a great night.
Bye, everybody.